Sciences, IGenX, MDL. These are labs that have devoted themselves to producing tests which are far more clinically relevant and follow the clinical picture of the patient. So, no. A negative Lyme test never indicates you don't have Lyme. Lyme is always accompanied by the classic bullseye rash, which always looks like a bullseye, with central clearing. They forgot to mention the tick with the American flag in the middle of the bullseye, because you got to have that too in order to be called a Lyme rash. No, of course not. There is a number of well-illustrated dermatological papers showing all the variations of a rash as it is expressed through a tick bite. So it's very handy if you've got one, because everybody and his brother can make the diagnosis from that. But no, that is not the only type of rash.
They can look at the rash and say it's not. They can look at the tick, the rash, and say, don't worry about it, it's nothing.
Don't worry about it, it's nothing.
Well, and many people get no rash at all.
Well, they don't get a rash, they don't remember a tick bite, they don't, no, of course, it's silent. But be aware of rashes and a change in your physical health. And particularly if you're in an endemic area. Look, I mean, look at Rhode Island. I mean, where do you guys go to vacation? You go to the beach, you go to Narragansett, you go to Cape Cod, you go to Block Island, you go down to Lyme, Connecticut, you go over to Westchester, Dutchess County, you know. You folks are in the highest endemic area in the country. So it pays always, I think, the Lyme diagnosis, particularly if you've been a healthy person and suddenly you just can't get over the wall. You start having sleep problems. Never had a sleep problem in your life. Can't go to sleep. You have multiple awakenings. You start to have bladder problems. You start to have urinary frequency and urgency. You start to have GERD, irritable bowel or gastroesophageal reflux disease. Never had it before. Starting to have migraines, headaches. You never had a migraine in your life. If you took one aspirin in 20 years, that would be too many. Those are red flags in healthy individuals. And if it doesn't go away, and you're in this endemic area, you think borreliosis, you think red cell parasite, and make sure that you go to a Lyme literate physician who can tell you pretty certainly and test you in the best manner possible. No knock on the general physicians and docs anywhere. Most of them are trying their best to do what they do well, which is to take care of people. But the information is so blocked right now, is so contentious, it's so political, that physicians are afraid. And then they're tired of fighting insurance companies for treatment. And they just say, oh, I don't treat Lyme, you know. You go to a Lyme specialist. Where? You know. So that's very important. Lyme disease only comes from the bite of a deer tick. I think so. I mean, there is other evidence maybe that it comes from the mosquito. But for the most part, it's deer tick driven. The Ixodes scapularis, if you study that tick and study its saliva, it's such a fascinating interaction between the bug and the spit and the gut of the tick. Can't believe that evolution is that clever, but it's that clever. The spit of a tick has got an antihistamine, an anesthetic, an anticoagulant, an enzymatic drill that goes through fibrous tissue. It's got a T and B cell inhibitor, all in the saliva so that the blood meal can be ingested unbothered, and the Borrelia organism thrives on that very mechanism. So for the most part, I think your deer tick is your culprit. Can you get it from some other insect vector? Possibly, but I wouldn't be too worried about that one. Lyme disease is the only disease transmitted by ticks. No, we talked about that. First World War, the tick louse was responsible for more deaths than all the gas and the bullets. Relapsing or trench fever killed more men in the First World War than all the ammunition, and it was a tick-borne disease. No. If you don't, co-infections with Lyme are rare. There's no such thing now as, I don't think, a pure Lyme case. I haven't seen one in a long time. It's tick-borne diseases, and I think there's usually more than one organism that you're having to deal with. Sometimes it is only one organism, but this area in the Northeast now has become much more a reservoir for more than one organism. So make sure that all your bases are covered. One of the problems we had initially before we discovered Babesia was that we were treating Lyme patients and they were getting well to a point, but they had this crushing, exhausting fatigue, and we couldn't get them over the fence. Some of the joint pain would go away, and some of the other symptoms, even some of the neurocognitive would be, but the exhaustion, one of the red flags of Babesia is that you can't exercise. You can't do aerobic exercise because the red cells have been robbed of their ability to give you enough oxygen to do a sufficient aerobic activity. So you're pulling from the pyruvic acid cycle and you're exhausted. So it takes 2 to 3 days to recover from a small aerobic activity that ordinarily you could do it falling off a log. So you have to be careful of these other co-infections because I think they go hand in hand with this condition. If you don't have swollen joints, it isn't Lyme disease. Well, I think we don't have to go much into that one if my presentation had any impact. You must have multiple symptoms to have Lyme. No, it's the other way. It can be the other way around. You can have just one swollen knee, and then that swollen knee can shift to the other side, and then suddenly your shoulder is going to hurt you, and then it will all go away for a while, and I'll be darned if you don't get a sciatica. So you don't have to have multiple symptoms all at the same time. The longer you've had the illness, the greater the likelihood is that you'll have more than one system involved. There is no such thing as chronic persistent Lyme disease. Well, tell about every one of the people in this room that there's no such a thing, and see how far you get in convincing if they want to donate to your research to prove that this is the case. Of course it does. And I don't understand, frankly, why now, after 20 years, we're still debating this problem. If you look at the research, the way that this biological organism operates, then it would follow logically that there has to be cases in which this organism is going to be chronic and going to be persistent. It's the nature of the biology of the organism to do this, to remain persistent, to hide, to evade, to mark itself in a way that immunologically you may not be able to counter it unless you have help from medical sources. So of course it does, and that's the big debate in the field. And that's why often you can't be treated long enough, and that's why I'm here today to talk to you. I mean, look, this is Rhode Island, Brown University, University of Rhode Island. Some of the best doctors in the country here. This should be no debate now. This should be done and over and done, finished. We should be trying to find out the best way to work with these persistent long-term problems, not debating whether or not they exist. I have 3,500 patients. Joe Perscano has 7,500, almost 10,000. Horowitz has another 10,000.